Just remind me, when was the first surgery that you had?
31st of January in 1997.
Very precise, okay. And that was when you had the mitral valve replacement?
Replaced.
Yeah.
Mm-hmm.
That was done here in Edinburgh?
Yes, it was done the old infirmary.
The old infirmary, okay. And when did you find out that the valve was leaking?
Just 2 or 3 months ago.
Okay.
I had been complaining about chest pains and was being treated for indigestion.
Yeah.
Took a pain one Sunday morning, 4 o'clock in the morning. Really didn't feel well.
Yeah.
And went to open surgery on the Monday. And doctor thought it was angina.
And Dr. Henriksen, your cardiologist, he said wrote to me about this, and he said you'd been feeling a bit breathless as well.
Yeah, very breathless.
Okay.
That had been going on for a wee while as well.
Okay. How long have you been breathless for?
About a year.
About a year or
Yeah.
so. Okay. Is it getting any worse? Or?
Yeah, I'm not able to walk great distances at all now.
Right. Okay. Did you notice anything else, like swelling of your ankles, or
No, I haven't noticed swelling in my ankles or anything. Just
getting more breathless?
breathlessness, and my appetite disappears quite a lot. You know, I just.
And the other aspect of this, which is relevant and is connected, is the anemia. I think you've been on treatment for a low blood count from your doctor for a while.
I've been on iron tablets.
Iron tablets. How long have you been taking?
It must be a year now.
Okay. And has that improved the anemia, or did they help?
I don't think so, no.
That's my understanding, is that the anemia didn't get better, and you've had other tests for that as well. I think they looked in your stomach.
Yeah, I've had, they checked me for bowel cancer.
Yeah.
Different.
And they didn't find any bowel?
No, nothing at all.
Bowel bleeding, okay. It does seem that the anemia, you've had some other blood tests done more recently, and we think the anemia is caused by the leaky valve. It's something we call hemolysis. So the jet of blood that's going through the leak in the heart valve is actually destroying some of your red blood cells. And it generally doesn't respond to iron treatment, but hopefully it will respond if we can fix the leak around the valve. So we're going to just talk a little bit about the procedure itself. This is a mechanical mitral valve, so you've been on warfarin, haven't you, since your valve was put in?
Yes.
And I think you stopped your warfarin a couple
of
days ago on Tuesday. Okay, so I don't have the result of the INR today, but we'll have that before we do the procedure. But obviously the warfarin effect will have come down a little bit, so we'll start you on some blood thinning medication again this evening. I'll give you an injection this evening just to get your blood thin again. We'll be doing this procedure under a general anaesthetic. I don't know if you've met the anaesthetist yet, have you? Have you met?
Yes.
She came out to see
There
you.
was one of the girl, was it?
Yes.
Yeah, she was in to see me.
Great. So you'll be asleep and you're not going to know anything about this. We'll be doing the transesophageal echo scan like we did before, but again, you'll be asleep before we put the probe down, so you'll not be aware of it at all, but it'll just be in your throat, and it might give you a little bit of soreness in your throat when you come round afterwards. And we'll have a catheter in the vein in your leg, and I'll probably put a catheter in the artery in your wrist as well, so there'll be a little nick here and a little nick in your leg. Similar to when you had the angiogram done recently, it showed that the arteries in your heart were normal. It'll be very similar to that procedure, just a little nick in the wrist here. And we can get some bruising either in your wrist, but particularly in your leg after this procedure. Sometimes
I had bruising all these years ago with the angiogram.
You remember? Okay.
Yeah, I do remember that.
So there can be some bleeding and bruising from the access site from the vein and or the artery. So once you're asleep, we've got the scanner and we've got the catheters in. We'll have a close look to see exactly where this leak is. We kind of know already, but we're going to get more precise and assessment of exactly where the leak is, and then we'll try and pass initially just a tiny little wire through where the leak is. We're talking about something that's quite small. It's only a couple of millimeters across, and that can be quite awkward to do, and it can take some time. So this is a procedure that can take, we were just chatting about that, it can take anything from an hour up to even 3 or 4 hours sometimes, so it can be quite a long procedure. Once we get the wire across, we can then put a catheter across through this little hole around the edge of the valve, and then we can implant a device through the catheter. This is the type of device that we're going to implant. It's made by St Jude Medical.
Yeah, it's a St Jude's valve I've got in.
Yeah, all right, okay. That's the same manufacturer. And it comes on a cable like this, And then the device, just once we've got this in position around the valve, we can just unscrew the device off the cable. So the valve is kind of sitting like that, and this will go just alongside the side of the valve where the little hole is that's causing the leak. And we pull this part of it into the leak, and that closes the leak off, it seals it.
Yeah.
It's just like putting a plug in a sink or a bath. So we're just going to chat for a couple of minutes about things that could potentially go wrong. Obviously we hope nothing will go wrong, but it's just things that potentially could do, and just to warn you. And the main thing to warn you about is that it's a procedure that may not work. I think roughly 10% of the time, for one reason or another, we can't get this device into the correct place. We will only deploy this and release it from the cable if we're sure it's correctly positioned and it is reducing the leak. There's no point in leaving it if it's not doing what it's there designed to do. And if it is in the right place, correctly positioned and correctly sized, it should reduce the leak straight away. So if it's not doing that, if it's not working, we'll take it out. Or if we think there's any risk of this breaking free, so if it's not secure, we'll check that it's securely, correctly positioned and secure. Otherwise, we would take it out, because if this were to break free from where we put it around the valve, then it could end up anywhere in the circulation. This is something we call embolization, and it could end up it would end up on the arterial side of the circuit, but it could be anywhere in your body really. If that were to happen, you might need a little operation to retrieve it, although sometimes, very often actually, we can get a catheter around the device and actually pull it out ourselves, so pull it out through probably through the artery in the top of your leg. But hopefully none of that will be necessary, because we check it secure before we release it, okay? But the main thing to warn you about is that it's a procedure that might not work. It is possible we might wake you up and say, look, sorry, we couldn't do it, and that's probably about 90% of the time it does work, but about 10% of the time it doesn't work, and we would just take the device out. Other things that can go wrong, we've mentioned that you could get some bruising and bleeding. Occasionally we can make a little tear or a hole in the lining of the heart, and it causes bleeding from the heart. We have to put a catheter in to drain the blood from around the heart. If we've got any infection on or around this device, or if there's already an infection in the heart, we don't think there is, but that could be serious if we've got any infection. So we'll be giving you a shot of antibiotics when we do this to prevent that kind of thing. And also if we've got any blood clots on the device or on your heart valve, then that could be a serious problem as well. If a clot got loose in the circulation, it could even cause a stroke. So we'll be giving you blood thinning medication. You've been off the warfarin for a few days, so that is a concern, but we have to stop the warfarin just for a few days to do this procedure. But we'll give you blood thinning medication as soon as we get you through. And as I say, we'll keep you on injections of blood thinning medication until your warfarin is working again.
It's levels back up.
So I'm going through all the kind of bad outcomes and things that can go wrong with this.
You've got to be told the good with the bad.
I have to warn you of these.
Or the bad with the good, I should have said that.
The other thing about this that's a particular concern with you is because you've got this hemolysis thing, this anemia that you've got, it's unpredictable whether this will cure that or correct the anemia. We are hoping that it will help, but it may only help if we're able to completely seal the leak and stop the valve leaking at all. And quite often with this procedure we can reduce, your valve is leaking quite a lot, and we can usually hope to reduce that to just a very mild leak. But even if there's a little leak left behind, your blood may still, you may still have this hemolysis problem, and you may still have the anemia. So we're optimistic that we can reduce the leak, but whether we can stop it altogether, I'm not sure. To completely seal the leak and have no residual leak at all maybe happens in less than 50% of the patients. That's our experience, is less than 50% of the patients that we've treated. So sometimes, even though we've reduced the leak, the anemia may continue. So that's all I needed to tell you about the device. But was there anything you wanted to ask me before we get you to sign your consent form?
No, I think you've been very informative. It's